Uh, Thanks for joining today. We are going to be talking about a new model that we have been working on down here in Houston, Texas. So all of us today on this panel are here in Houston, and we're excited to share with you some work we have been doing, some research and new technology development, as well as really developing a framework and an organizational guide for improving the way we design and implement new technologies for intensive psychiatric settings. Much of our focus and a lot of investment has been both time and financially in the outpatient space. And so we're really going to talk about today how important it is that we think about new technologies for populations that have significant psychiatric illness and are in significant psychiatric pain. So we're excited to talk with you all today about that and our model that we have developed, as well as some applications across really diverse settings. Jessa, we're going to share the slides. A little bit of housekeeping is that all of our Q&A will not be in the chat, and instead it will be in the Q&A feature of the Zoom. So please, as questions come up, just put them in the chat. If there's a really big burning question, happy to take it at the end of different presentations, but we will also have a formal Q&A session at the end to really discuss the model and the applications that we have been doing here in Houston. So use that Q&A feature to ask any questions as we go along. So a brief introduction of our presenters. We're going to be talking about a model. The acronym is TIME, and it stands for a new technology design and implementation approach across intensive psychiatric settings, really for mental health end users. That's where the M and the E comes across. And it's incredibly important, like I stressed, because we're focusing on these intensive psychiatric settings, acute, intensive, residential, and inpatient settings. And so much of the work in mental health has been done in the outpatient space, but we have so many other levels of care, more intensive levels of care that really have not had the level of innovation and technology implementation for a lot of reasons. And that it's really about time that we really think about reinventing this space and thinking about how we can integrate new technologies, but it's very challenging and very difficult, and particularly in settings that are often under-resourced. So we're taking a little inspiration. So there was we have another kind of we have a famous fellow Houstonian who was here last night, and we're taking a little inspiration to wake you up this morning from her. So she was here. I hope you can hear it. And so take a little inspiration from Lizzo to really motivate us this morning to think about improving these intensive psychiatric settings. It's about time that we think about changing and integrating new technologies very thoughtfully, very clinically sensitively, and thinking about designing them in a way to really reinvent this space to improve outcomes and safety, as well as reduce trauma. A lot of these settings can be very traumatic and very traumatic experiences. You also have poor outcomes for post-discharge, for example, from inpatient psychiatric settings where risk of suicide and overdose is very high. So, it's about time that we change these settings and the way that we use or sometimes don't use technology. So TIME stands for Technology Implementation for Mental Health End Users. And there are really two important components: the technology development, but that mental health end user. What does that look like? How do we truly iterate and integrate information from the end user in order to create usable technologies in these settings? So I'm Michelle, and I'm coming from the Menninger Clinic, where I'm director of research, and I'm also a psychologist by training. And we really study and think about new ways to integrate and leverage new technologies to improve intensive mental health treatment. And I'm doing the introduction right now. We'll also have Jessa Westheimer, who is the clinical innovation engineer at the Menninger Clinic, and she's going to give us an overview of this time model and an example of how we're currently implementing it right now. Then we'll have Peter Jacobelli speak on an application of the time model to our outcomes system and how we are improving that utilizing this model. So Peter is a clinical research engineer at the Menninger Clinic. Then we will have Dr. Jan Lindsay talk about a web-based program that was implemented in a veteran population. So Dr. Jan Lindsay is director of the telebehavioral health for the South Central Mental Illness Research Education and Clinical Center, the MIREC, and she's also co-director of the MIREC. She's also associate professor in the Department of Psychiatry at Baylor College of Medicine. Then we'll have Dr. Nidal Mukadam speak on cultural and practical considerations, as well as share some important pilot data and work that they have done in a acute inpatient unit. So Dr. Nidal Mukadam is associate professor in the Department of Psychiatry at Baylor College of Medicine. Finally, we'll have Dr. Ashu Sabartwal speak on a collaboration with Dr. Nidal Mukadam on applications and adoption of this technology in intensive mental health settings. And he is department chair of electrical and computer engineering at Rice University here in Houston, and a full professor. So we are just very excited to be here today. We'll also have a discussion summary at the end and final Q&A, like I mentioned. And of course, please put any questions as they come up in that Q&A feature in the Zoom. The chat feature is disabled, so all questions should be in there. Just to give you an overview of where we are coming from here in Houston, we're very fortunate to have a diverse innovation ecosystem that we are really have formalized and thought about within the context of this new time model. And there's two main components of this ecosystem: our clinical care and hospital settings, which fall under the umbrella of Baylor College of Medicine, as well as phenomenal academic institution and support from Baylor College of Medicine with clinical research, as well as Rice University with where they have a very strong engineering commercialization pipeline. So from the clinical care standpoint, like I mentioned, they all fall under Baylor College of Medicine, with the Menninger Clinic being a private pay inpatient and outpatient psychiatric hospital. Ben Taub Hospital here in Houston is a community mental health acute inpatient and outpatient facility. And then the Michael E. DeBakey VA Medical Center, the Houston VA, which has veteran inpatient and outpatient mental health care. So this ecosystem has really provided us a phenomenal population, diversity of population and settings where we can begin to test and design and implement new technologies across diverse populations and test things that maybe we wouldn't be able to otherwise. We're very fortunate. We're all within about 10 minutes of each other here in Houston. So we're very close. And of course, Zoom makes it even closer. But these are our facilities with Menninger in the top left, Baylor College of Medicine, and Ben Taub on the top right, and then Rice University bottom left, and then the VA. So really excited that you all are here today, and thank you for joining us. And I'll let Jessa take it away with an overview and definition of the time model.
Good morning. Can you hear me okay? Okay, perfect. Let's see if I still have slide control. I do. Okay. Good morning. My name is Jessa Westheimer. Like Michelle mentioned, I'm the clinical innovation engineer at the Menninger Clinic here in Houston, Texas. And so I'm really excited to be talking to you today about the time model. It's been a long time in the making to sort of think about how we can implement digital transformation within intensive mental health care settings. You have to go about this really, really carefully. And so there's a lot of moving parts, I will be honest. There's a lot of moving parts going on. So I just ask, if you have any questions, feel free to ask, put those in the Q&A feature. And I will try and go through this as delicately as possible. And yeah, so welcome to the time model. So an important thing about the time model is when we were first creating this, the overarching idea was we wanted to create a model for digital transformation, which digital transformation is implementing digital mental health care into and new technologies into an inpatient setting. So we wanted to think about how we could incorporate all of these different steps from existing design processes across disciplines, across software, across technology, across user-centered design, and really think about how those steps function together and how we could implement them whenever we're trying to facilitate digital transformation. So the first step that we noticed, so we looked at the waterfall model of software development, user-centered design process, and rapid application development, which are all established and validated methods of developing new systems and new technologies. And so the first one we noticed that was kind of consistent across all of these processes was planning. So this was really information gathering, kind of specifying the requirements and sort of the context for the use of the eventual implementation. Next, we see analyzing, which is in the first two processes we looked at. This is a bit of a sort of continuation and narrowing of the planning phase, where you're taking all of this information that you gathered and you're kind of defining requirements, specifying specific behaviors and functions of the new technology or the new innovation you're developing. Next, we see prototyping. And prototyping is kind of, we define it as from a scale of low fidelity to high fidelity. But this prototyping is very, very much the stage where you're initially, anything is possible, basically. You can take any idea and all of these just vague kind of requirements that you have and then build something out of it. And it can be as simple as like a sketch on a piece of paper or just a drawing on a whiteboard, which you'll see. Next, we have building. So this step is kind of interesting. We'll talk about it a little bit, but it's more of the like actual process of sort of creating that. So here, for example, in the waterfall model of software development, you see coding is an example of this. Moving on, we have testing, and this is where you get user feedback and you're doing usability testing. So you're thinking about the end user and how like functionally they're going to use this. And the next step, we noticed there was a step where the process was finalized. All of these steps kind of come together and they have a final deliverable, which they're implementing. And so we noticed the prototyping, building, testing phase was very much iterative. Across all disciplines, it's important that you iterate, you continuously prototype, test, build, prototype, build, test, and then repeat this process over and over until you have the optimized final deliverable. So from here, we really took all of these steps that we kind of defined and narrowed them down in order to create this time framework. So all of these steps, planning, analyzing, prototyping, testing, iterating, finalizing, is what really makes up the core of the time framework. So in the time framework, a key piece about it is that it's parallel processes. So we're thinking about the what and the how. So first, we're developing a high-tech prototype, which is the what. This is what you are going to develop, what technology you're going to use in order to create digital transformation, in order to improve mental health care within the setting. The next is the how. So you can think about these pretty generally. The high touch protocol, or the how, is how you're going to use the what, or your high touch prototype, in order to effectively implement that system so that it's usable, that it's accessible, that people will continue to use it, and it's a successful implementation. So we have this sort of idea of high tech and high touch. So the technology component is really any technology that you're trying to implement. It's pretty easily defined and understood. The touch component, on the other hand, is like a little bit more confusing. So this is really the human side of things. So for example, you can have any one intervention along either dimension of the scale. So things can be low tech or all the way up to high tech. Things can be low touch or all the way up to high touch. And so we'll frame the example that we're going to go through within this dimension, or within this matrix. So we'll be able to explain a little better. So in order to better explain the time model, I think it's really simplest to understand within the context of an ongoing project. And so this is a project that we are working on at the Menninger Clinic right now. Currently, and many of you are probably aware of this, there's an existing issue that we've noticed based on research, is that Q15 checks cannot prevent risk incidents in an inpatient psychiatric setting. And so, for example, this is a figure that kind of describes this, but Q15 checks are it's considered the gold standard within inpatient psychiatry for patient safety risk management. So every 15 minutes throughout the night, a suicidal patient, or a patient who is high risk for suicide, will be monitored and checked in on. Door opens, light comes in, sound comes in every 15 minutes throughout the night. This will not only disrupt their sleep, but it leaves these unchecked windows of time where suicide or any form of self-harm can happen, because what happens between point A and 15 minutes later? It only takes 6 minutes to die by suicide by asphyxiation. So there's really some issues with this. So Q15 check would be a high touch solution. It's about as high touch as you can get, but it also incorporates a low amount of technology. It's really just a matter of pen and paper tracking the monitoring sessions. So we have it positioned here, a high touch, low tech solution. So we're going to start applying the time model. So in the planning step, this is where we define and we scope. So initially, we conducted interviews with end users. So in this case, this would be the clinicians, the nurses, the people who are actually conducting the Q15 checks. So we want to get a better understanding of what would be useful, and in their experience, what is the best sort of guiding requirements, not necessarily specifics, but the guiding requirements and functions and behaviors that they would want to see in a risk management system. So kind of really reinventing all of this and thinking about it from the ground up. So we have these three sort of quotes that we pulled from these interviews. So the first, Q15 checks are about as high touch as it gets. Research shows that Q15 checks decrease sleep quality, which increases suicide risk. That's called the safety sleep suicide spiral. Q15 checks also leave an unchecked window of time where patient safety status is just completely unknown. And so we move from that to the pain points or the issues with the current system into the new risk management system and what we think it should do. And what our end users, or these nurses, clinicians, researchers that we interviewed, what would combat these issues, these pain points. So first, you minimize unnecessary interventions, give patients more independence, reduce sleep disruptions, and be able to alert nursing staff by continuously monitoring the patient, ensuring that we know that the patient is safe without necessarily having to be physically in the room with them. So the innovative solution that we are developing is wearable-based remote patient monitoring. So a patient would be wearing a wearable device, and that this would be able to alert nurses in real time to changes in their patient safety status. So the idea is that where they're wearing a wearable, they're wearing a wearable device, and the derived vital sign will be output in real time to a monitoring dashboard where nurses can intervene only as necessary. So high touch becomes touch when necessary, or touch only as needed, just enough touch. So Q15 checks migrate over to wearable-based RPM, so decreasing the touch and increasing the amount of technology. So this is really a high-tech solution. And so we're trying, in all of these, it's not necessarily the best option to be high touch or high tech. The idea is to optimize the level of touch and tech to best suit the end user. And so today you'll be seeing a lot of different examples of how the dimensions of touch and tech can be optimized in order to best suit the end user, especially within the context of the time model. And so now we move into analyze. With this high-tech prototype, we're really thinking about the wearable device, how it's streaming data, and then how it's being visualized on a monitoring dashboard. With the protocol, this is really just the general framework where suicide risk is assessed and then monitored via wearables, and then intervention is only as necessary, but in a way, but can prevent suicides that otherwise a Q15 check might not. Moving on into the prototype phase, here's an example of the user interface that we started building for a patient monitoring profile. We see that there are paper wireframes, just really quick sketches of what a user interface or might look like for one of these monitoring dashboards. So you just have like really quick sketches, like little stick figures and things like that. But moving on, when we did user research and kind of like understood, we pulled different aspects of all of these different models in order to create a more robust digital wireframe, a more robust prototype. So moving on into the testing phase, we took this digital wireframe and then we conducted user testing. We showed them, they interacted with it. It's not incredibly functional, but it's enough to show you like what is missing. So the first question was, what does it look like to monitor multiple patients? Whenever we presented this user interface, people wanted to see multiple patients at once, not just one. So in our next iteration for the high-tech prototype, we showed a digital wireframe for what a monitoring dashboard for many different patients would look like. And then moving on for the patient monitoring profile, we continue to iterate that digital wireframe by showing how in the high-tech protocol, how the alerting system would function. So we're moving forward and to see how different versions of alerting would happen. And then finally, in the implementation phase, we're looking at the high-tech prototype and the high-touch protocol, which is both the monitoring dashboard and the alerting system. And so in these next few examples, you'll see sort of the prototype of the monitoring dashboard, but then in real time, how a nurse would be notified and how they might go about what the use protocol and how they would go about addressing the situation and going about the crisis intervention protocol, but then also interacting with the user interface of the monitoring dashboard. And then, so overall, plan, analyze, prototype, test, iterate, implement. As you can see, it's kind of a repetitive process, especially these middle few steps. Prototype, test, iterate happens over and over. It's a cycle until you end up with like the most optimized solution. And you probably never will. So prototype, test, iterate is just such an important and central feature of this. You have to continuously be examining your high-tech prototype and your high-touch protocol to see what you can be doing better for your patients. And so right now, with this ongoing project of trying to implement wearable-based remote patient monitoring with this high-tech monitoring dashboard and high-touch protocol, we are currently in this step, the prototype, test, iterate phase. We're working on different aspects of each, the prototype, the monitoring dashboard, and the protocol or how it's going to be used. All right, so that's my last slide. Thank you very much. Sorry I went over. I'm long-winded and very excited about this, but thank you for your time.
That was awesome, Jessa. All right, next we'll hear from Peter, who will talk about application too for the time model. Go ahead, Peter.
Okay, thank you, Michelle, and good morning, everyone. So yeah, I'm just going to be talking about an example of how we're implementing the time model here at the Menninger Clinic. So as we've seen from Jessa, the transition to an implementation of a new technology in a healthcare setting needs to be kind of an organized endeavor with the entire process from the conceptualization to the final implementation being approached systematically. That being said, the implementation of novel data systems and technologies a lot of times fails to take into account both the technological and the end user specific needs simultaneously. Here at Menninger, we've seen the consequences of that flawed approach firsthand with the current iteration of our data system, the Outcomes Data Manager, or ODM, and its two predecessors. So now, as Jessa mentioned, we do have continuing projects. On our fourth iteration of our data system manager, what we're calling the Integrated Database Management System, or the IDMS, we're taking a different, more systematic approach to its construction and implementation with the time model so that we can better prioritize both its efficiency from a technological standpoint and the interaction between the information architecture and the end user, which in this case is clinicians and researchers. So as we began to kind of identify the need for a shift in the way that we manage and interact with our data, we first had to understand its limitations from a technological perspective. And we did this first by defining the overarching problem. As you can see here, our current data management system is kind of composed of several isolated subsystems. We have our main outcomes project here. We have several different studies. And these subsystems have historically impaired the efficiency of how we manage and interpret our data. So as we began to kind of conceptualize the next integrated database management system, it became pretty clear that from a technological standpoint, the primary goal had to be full-scale data integration between research-based data, study data, and clinical data, so that we could better account for the high-tech aspects of data management and to more efficiently meet the needs of our end users. So from here, we kind of sought out the input of everyone currently involved in the maintenance of the Outcomes Data Manager so that we could pretty clearly and cleanly diagram its architecture, making it more visually accessible and helping us to better understand its full scope. So you can see here, so here we have the high-tech, low-tech matrix and that Jessa mentioned earlier. And a big part of understanding how to go about creating or iterating another data system from your old one is understanding where its equilibrium is at on this matrix between high-tech and high-touch. So we decided that it's about in this place, slightly high-tech, slightly high-touch, but definitely area for improvement, especially as far as our end users are concerned. So from here, it was necessary to identify the primary issues or the pain points that Jessa talked about with the data system in its current state. By seeking out the feedback of those involved in the maintenance of the data system and its architecture, like I mentioned before, as well as seeking out the input of current end users of the Outcomes Data Manager, we were able to kind of identify recurring complaints and define those complaints as primary areas of concern. Once the pain points of the system had been established, feedback was sought out. Feedback was sought out from the same individuals pertaining to what the new data management system should be able to do, as can be seen here. So we had people discussing integrating the data from all the different sources. As we mentioned before, that was our primary goal: research studies, EHRs, clinical outcomes data, etc. We had people talking about having different reporting options for different types of user needs. So that's, again, catering to the needs of the end user. And we had people talking about making it more straightforward, intuitive, simplistic. So we were able to take these, this feedback, and think about how we can use it to implement new protocol or new technologies and new protocols moving forward. So it's important to gather the feedback, not only from the pain points, but as well as from how we should go about fixing or resolving some of those problems in the future. Because while we can address and try to patch some of the issues based simply on the pain points of the current system, identifying and defining the more specific components of the outcomes data manager that could be improved helped us to prevent further issues in the future by tailoring the design of the system to more end user specific needs in later phases. So again, having a better comprehension of the technological and user level shortcomings of its predecessor, we found that defining the necessities of the next iteration, the integrated database management system was much more informed and allowed us to pinpoint specific areas for improvement when it came to interaction between the end user and the interface, as well as to ask more focused questions about what improvements can be made to optimize efficiency on the technological backend. So that's factoring in both the high-tech prototype and the high-touch protocol. So here's again a diagram of our high-tech prototype that we showed you earlier. And here's the full-scale visualization of that diagram that makes it more accessible and helps us better understand its scope. Here we have analyzing the needs of the next iteration of the data system. So this initial empathy research played a big role as we started to conceptualize the protocols necessary for aiding in the interaction between the end user and the interface. So when a new technology is rolled out, it really needs to be accompanied by clearly laid out protocols for the use of that technology so that we can proactively address user level issues and facilitate a smoother transition from the previous data system. If substantial changes are made at the technological level, then there's likely going to be a big change in the way that end users, our clinicians and researchers interact with and employ the new data system. So by asking questions like, how can the simplicity of the interface be maximized so that user error is minimized preemptively, we can define more clear and concise protocols to accompany the novel data system so that we can ensure that the increase in technological efficiency is accompanied by a more user-friendly interface that better addresses the needs of its end user. So here we have an example of gathering empathy data to better analyze the needs of the current system based on what clinicians found deficient in the previous system and what would best benefit them moving forward as we iterate into the next system. And once we have the technological needs of a data system are defined and the use protocol changes are more clearly laid out, that's when we can start constructing our low fidelity prototype. So again, we have these paper wireframes that Jessa mentioned earlier. And really, as we designed the prototypes, we placed a huge emphasis on effectively translating this novel backend architecture, including a new data storage system and new methods of data transport from their respective sources. Again, that integration into a user level interface that addresses the shortcomings of the previous iteration of our data system in the most user-friendly way possible. So again, using that empathy research gathered to translate high-tech protocol or high-tech technological interventions into a more user-friendly interface. So because the novel data system was conceptualized with the end user in mind, the simplicity and ease of the use was again prioritized in the prototype build out so that technological efficiency could be maximized while limiting that potential for user error. So by designing the low fidelity prototype with simplicity in mind, we also found ourselves a lot better able to address the specific needs of end users gathered from the empathy research in phase one by tailoring the interface layout to specifically account for flaws in the previous system via a user-friendly front-end translation of the more complicated underlying architecture. So from a more high-touch perspective, there's really a direct relationship between the technological intricacy of the interface and the use protocols associated with it. So as the interface and its use becomes more intuitive, due to the simplicity of its design, then the use protocols can be significantly less intricate, less complicated. So as technological and protocol-related feedback is gathered and assessed, specific enhancements to the prototype will be made in a subsequent iteration. Issues identified during the test phase, whether they be technological or protocol-based, can kind of be categorized as acute or multifactorial. Acute issues pointed out during the initial test run can generally be rectified locally with like very little impact on the system as a whole. And whereas the resolution of multifactorial technological issues, on the other hand, is going to involve a lot more change, which will require a lot more change to the protocols associated with the technology. So again, rolling out that test phase and gathering in the data to iterate another prototype needs to be cyclical. So as I touched on earlier, the integrated database management system is the fourth iteration of our data system. But it's the first iteration in which the time model has been used to intentionally guide end user-centric technology and protocol development in the design and construction of the previous iterations. So sufficient prototype test iteration cycling was more or less ignored, which resulted in the low fidelity prototype also being the final implementation. Referring back to the data gathered through empathy research and the analysis of needs for the integrated database management system, we can decide when an iteration is ready for implementation based on the test feedback. So we can see where the ODM was, where the IDMS needs to be, and we can test and iterate until we're ready to implement based on where we feel that the IDMS needs to be. So yeah, that's it for me. From here, I'll pass it along to Jan.
Hey guys, great to be with y'all today. Thanks for that. Jessa, you think I can manage my slides? Okay, let me roll through. So I wanted to anchor my discussion today. I'm a clinical psychologist and I do a lot of research in virtual care. And what we did here for this study, it was about a 5-year study and we did it pre-COVID, so be gentle, about kind of adapting what we would call a high touch traditional psychotherapy intervention into a web-based program, but we also wanted to integrate coaching, so video coaching. So we chose Marilyn Cloytra developed a really nice kind of present-focused trauma-based intervention for trauma survivors. And so within the VA, we wanted to make our treatments a little more accessible. We were getting some feedback that our traditional evidence-based psychotherapies for PTSD, patients wanted to be able to do it asynchronously. Another point is that women veterans, we just recently published, are twice as likely to actually opt for virtual care. So we knew we wanted to integrate technology, but we didn't want to lose the kind of effectiveness of this in-person synchronous intervention. So we translated some of, and this is again, National Center for PTSD, Marilyn Cloytra, their work, translating this into an asynchronous web-based program, trying to up that tech a little. And we chose some skills that we thought women veterans in particular, but patients could practice. Emotion regulations, very important, and improving interpersonal functioning. And like the time model, we really do a lot of qualitative interviews, a lot of focus groups, what's important, and what pieces can we translate into these higher tech interventions. So we wanted to talk about coaching. That was new. I know John Toros does some wonderful work about digital navigation, but we wanted to do some mental health coaching, which is different than these were mental health clinicians delivering this treatment. So we really did a lot of training on coaching, and it was a shift for me, certainly, about coaching to the technology, coaching to the program, a lot of motivational interviewing, metabolizing the content, but it is quite different than individual psychotherapy. And so we're really trying to study this coaching aspect. I'm sure others in the audience are also interested in that. It's really important because, as we found, I started in this space, more than 15 years ago, and thinking that we would be able to transition a lot of mental health treatment into virtual care and these web-based and app programs. And we just haven't found, certainly within the veteran population, the uptake that we were hoping for. So we're trying to think about these creative solutions to keep the human, but try to offset a lot of the work that we do. Because a lot of cognitive behavioral therapy, it's homework, it's practicing, it's skills in your real life. So what piece of that can we offload into the technology? So this first study, around 80 veterans, trauma-exposed veterans, rural, we were funded by Office of Rural Health, but we also saw there was a real need here to do this online intervention. So we did this pre-COVID, and so it was a little clunky that we were doing synchronous web-based program and synchronous coaching to kind of understand how we can integrate those two. We found that it was feasible and acceptable. One of the findings that I'll discuss later was there were some tech barriers with sharing screens, because it was before we were all used to COVID protocols, but symptoms were reduced in a similar way to in-person care. So this first study was just feasibility. Can we integrate technology into this STARE, which now we call Web STARE program? The next iteration was around 32 veterans. We wanted to see whether 5 sessions, so again, reducing the touch, increasing the tech, so that we can help with capacity building, because that's a major issue, as we all know. And so we wanted to see whether 5 sessions, so every other week coaching sessions, would be feasible. Would we be able to get a reduction in symptoms? And we were, but mostly here, we were really interested in what is the experience. As a psychologist, I thought, oh, people are really going to want more and more therapy. And that was not the case. People like working at their own pace, doing this asynchronous approach, working, especially women veterans we were finding. And these studies are not exclusively women veterans, but they're 60 to 70% women veterans, depending on the study, which is much higher than the 12 to 15% that we see within VA. So we're really targeting the needs of women veterans, particularly those with a military sexual trauma experience. And they were saying, I like having the autonomy to do it outside of work hours. So this is where we hear this kind of iteration piece. Coaching matters. We really need a guidepost, accountability. They like the sessions, but this metabolizing and applying it to your life was something that the coach was really necessary for. So we got that check, right? If we do an asynchronous approach, we definitely need the coaching. But do we need it to be video? Now, I'm a big believer in video telehealth. Our team has published some papers about comparing video to audio only, but this was we wanted to understand about the intimacy piece. So if you are going to do a lot of tech, what does that human piece look like? How important is the video piece? So we, again, analyzed our qualitative data. We have over 200 veterans that we've conducted these qualitative interviews with, and it turns out to be very important that they want to be seen, and they want to see and be seen. When we learn in developmental psychology, the importance of mirroring, more of a connection, more, again, the accountability idea. And so if you're interested, I'm happy to share any of these papers. And this final piece, kind of the cherry on top of what we were doing for over these 5 years, was we conducted a non-inferiority randomized controlled trial comparing 5 sessions, still getting the 10 session content versus 10 sessions. So every other week, is that equal to every week sessions? And it turns out that it is equal, statistically significantly equal. So in this non-inferiority trial, it shows that 5 is equal to 10. But I did want to take a little time to look at the signal is going towards more connection is better, but we don't understand, so these rates, so we were studying PCL, PHQ-9, so PTSD symptoms, emotion regulation, HUDA. So we were wondering, how are people getting back out into the world, their social support, accessing social support. And so it was equal. But again, I think that our takeaway point is this coaching matters and the video matters. I'm going to try to hurry up. So this was just our summary here: liking self-pacing, liking the connection with the person, liking being at home. And again, women veterans especially are liking the convenience of being at home, the safety, the comfort, feeling more open. I love seeing patients in their home. I have to excuse myself. I'm in the corner of my hotel room. I usually have much more welcoming environment, but you feel like you're being invited into their home. And I think for this audience in particular, the technology challenges did not deter future interest. And so, yes, it was a little clunky at the beginning. We were trying to do multiple platforms, but they were engaged, and they said, we know about technology. We know that this is going to take us a little bit of practice. And so I'm going to leave you with this last statement, which is sometimes we have to go beyond the preferences. So sometimes patients will tell us, I'll just pick up the phone. Well, that's because they like to multitask. Or we want to ask, do we really need the weekly sessions? Is that just the way we as mental health clinicians have been trained, that you need to see patients once a week, for an hour? And we really need to be getting creative, capacity building, but also the effectiveness is very similar. And so let's think about the kind of human, the kind of touch we need, and also increasing the kind of slick technology aspect. Patients really like the videos, they like the interactive tools, they like to interact with their family members. And so we were learning a lot. Happy to share, but I also want to give a shout out to my pivot team back in Houston. So thanks, y'all.
Awesome. Thanks, Jan. We are going to move on to Nidal Mukadam.
Thank you. Can everybody hear me, I hope?
You're good.
Camera on. Thank you, everybody, for being here. In this section, we are going to present the diagnostic culture and practical considerations that surround implementations of measures such as time. And in the spirit of high tech versus low touch, we're going to talk a little bit first about, well, what happens when we try implementing these things. First, we run into what are the patients like and what do they know? So age, educational level, cultural background, etc. Then we have to think through, of course, what are the target symptoms that we would like to have an impact on, and specifically, what is the impact that we desire? Then, as my previous collaborators have mentioned, we have to determine how much the user will participate. So really what this leads us as researchers to think about is, are we doing operational or foundational work? Foundational work is more the conceptual, here's how things are built, here's the box in which you have to build this. And operational work will be more focused on the, how do I make it work in details? How much battery does this consume? Who can use it? What type of phone do they have to have? What type of technology knowledge do they have to display, etc. And so in this next set of slides, I will focus more on foundational work, and I'll tell you why in a second. That's because our operational aspects are going to be very demographic dependent. So once we build the foundation properly, everything that we do will have to be tailored to the target population. And this is one of the demographics I want you to think about. If you are dealing with a younger population below the age of 50 in the United States, for instance, 95% of those will own a smartphone. But as you get to your elderly population, it's going to be closer to 61% or even less, depending on where you are. And then if you are dealing with an underserved population, connectivity and broadband services will display a lot of disparities. And so really there's a lot of operational challenges that we need to deal with And we are going to have to also wonder about how this affects use of these technologies to bond to other people, because a lot of what we're doing is saying technology can help you, but technology can also help you within your environment. So in a testimony to how much operational challenges we have, this is a study that was done teaching patients with serious mental illness about basic technology skills: connect to Wi-Fi, check the weather, take a picture, add a contact, etc. And that study sadly showed that our patients, those with SMI, will have very minimal skills. They do improve, they are receptive to learning, but this is just to highlight that after you build the foundation, you have to keep in mind that the operational aspect will have to be very carefully tailored to our psych patients. So once we've determined that, we are going to go a little more foundational here and talk about the desired impact. What we are looking for are interventions that provide close, consistent monitoring, that are minimally intrusive. And I say this in the sense that they have to be minimally intrusive to the person, but also minimally intrusive under technology use and data usage, etc. We want those technologies to properly detect patterns and be usable to provide feedback to the patient, not just in terms of education, but also ultimately in terms of treatment, because what we want is symptomatic improvement. And so that leads me to a super foundational exercise here, which is one of the challenges in mental health is, what am I treating? Oh, it's great, I want a desired impact, but do I go by symptom? Do I go by diagnosis? Do I go by label? Do I go by what the patient says? And this is a question we've had to answer again and again. In psychiatry, you either have a diagnosis or you don't, and that is called categorical diagnosis. And of course, we use the DSM in the US, and so it started off with the DSM-1 in 1952, and it has grown to the DSM-5 TR, which has more than 265 disorders. So this relies on symptom cluster recognition. And it has to be, you have to have 5 symptoms out of 9 over a 2-week period, etc. This doesn't answer the question of what happens when you no longer meet criteria, should the diagnostic label remain, and can I use this in my technology work? And so while this is useful to standardize clinical practice and financial perspectives, it is not necessarily what our high-tech aspects require. So what I would invite you to think about is using a more dimensional approach. A dimensional approach basically says that your symptoms are on a spectrum. So think a symptom or a dimension, but not a diagnosis. We don't care if the symptoms occur together. That is a consideration for later. The NIH has already published RDoc, which is a beautiful document that says, hey, here's a framework to integrate all these basic and neuroscience research and then adapt it to clinical practice. Don't get stuck on if the symptoms happen together. Don't get stuck on the cluster part. Get stuck on whether the dimension is there. What is the etiology of this dimension? What is the threshold that would be considered problematic? Because this is only when I care about it. If it's not problematic, I could do some prevention work, but it would not be a priority all the time. And then, is there comorbidity? So some dimensions here will be impulsivity, sociability, agitation, insomnia. Insomnia and agitation from the bottom, those would be especially relevant for our time intervention because they are predictors of self-harm and predictors of escalation on an inpatient unit. Sociability is essential because when you are admitted on the inpatient unit, you are in fact in a milieu that we hope is therapeutic for you. So that is a huge aspect to consider. And impulsivity is basically, are you going to think through what you're doing? Or will you do something that's potentially damaging for you? And will you consider the consequences? And so, of course, you'll see none of these carry a formal diagnosis in the DSM-5, but they are very useful when we design any technology intervention. So translating this into an application or an intervention, what you'll have is at the very bottom of your triangle, a common base. I am monitoring for XYZ, and if XYZ hits a certain threshold, I will send an alert. The alert could be to the patient or the end user who is a mental health professional. The alert could be tailored. I am then going to take that alert and see if it applies to interactions. So is this just affecting my individual subject, or is it affecting how they interact with the world? So that's a really important dimension right here. And only the tip of the iceberg is personalization. What the user sees on their screen, their use dashboard, etc. That is actually a very small part of it. Even though people ask about it a lot, it's actually not the most foundational aspect of what we do. And so when we look for alert thresholds, the way you would want to think about that is we want those thresholds to be personalized, but we also want them to cover common bases for our individual patients. We want to make sure that we ensure staff and patient safety, that we detect early agitation, for example, on the inpatient unit, because that, of course, that allows us to decrease aggression. If you detect agitation, you could perhaps say, you know, let me give you some medications if you need it, or would you like to go to a quiet area, or you haven't had a lot of oral intake, do you want to kind of talk a little bit about that, are you feeling more depressed, etc. So those alert thresholds are non-diagnosis specific, but when you build an intervention you want to think about that, because these are useful dimensions. The sociability dimension, which I'll mention in a second again, will also show in terms of isolation, and you know that when we are depressed or when we are angry, we isolate more. And so focusing on this one dimension of sociability that has been of interest to our team for a while, these are factors such as your social network size, how many people you talk to, the frequency of contact, and the type of interactions. And sociability is implicated in several mental health disorders. I'm going categorical here. So major depressive disorder, post-traumatic stress disorder, ADHD, schizophrenia, and suicidality. We know that these impacts exist. We know, for example, that when somebody is more depressed, they will have decreased interaction with others, they will have isolation, and they will have decreased enjoyment in those interactions. If they have post-traumatic stress disorder, their interaction might be a little more volatile or include avoidance. If they have attention deficit hyperactivity disorder, there is an impairment in the one-to-one interactions with blurting out answers, for example, and some impulsive group interactions potentially. And with schizophrenia or chronic psychotic disorders, you will see a decreased drive to socialize and an impaired one-on-one interaction very often. And so when we think of our time effort, we think of sociability as imperative because we are gonna want to know how this person is interacting with the therapeutic milieu in which they're in, but we want to be minimally intrusive. And of course, once we try to implement these interventions, we do expect that those same psychiatric issues I talked about will carry some very specific challenges. So I would expect, for example, someone with a chronic psychotic disorder to show paranoia about the technology we're using, somebody with trauma to have a lot of hypervigilance and hyperarousal, somebody with a personality disorder to be mindful of the technology enough that it's hopefully not, but it could potentially make acting out a possibility. And with mania, we're going to see maybe more irritability or more of that, oh, are you watching me through that screen? And I go punch the screen. And, it is very complicated when you're on the inpatient milieu. And those challenges we do expect, but those challenges are also avoidable by proper psychoeducation and if the technology is truly minimally intrusive. And so what we've done so far, I'm going to take you into some of our sociability work to kind of give you an idea of how this could actually be implemented. The way sociability is assessed currently is very basic, and it is via self-report in questionnaire-based items. This is, of course, subject to bias and recall errors. It produces a reporting burden, and it's very difficult to get fine-grained information. So it is also very dependent on the patient's current state. So if I'm happy right now with individual X, I would say, oh, they're my friend. If I'm mad at them, I will tell you they're not my friend. So this is really not objective. If you were to use sensors, which has been tried, they are usable in a controlled scenario only. So I could give you a Bluetooth chip and I could know who you're talking to. And that's super helpful, for example, on the inpatient unit, because I could then know if you are socializing, and that could be a marker of your depression. But that is only usable in a controlled setting, and we cannot really control who else is going to wear that Bluetooth chip. And so what we've done is kind of had a wish list. We would like to assess sociability from free living audio. We would like to assess these sociability factors automatically, minimally intrusively, and in a privacy preserving manner. And I really cannot emphasize this enough. We never analyze content. We don't want to hear the words the patient is saying. We just want to detect this automatically. And the goal would be to get information such as social network size, the average number of unique speakers, because that tells me how many persons the subject has interacted with, and whether the interaction is dyadic or group. And in that interaction, is my patient active or not? Is my patient actually taking an active role in the conversation, or are they actually just standing on the side? This looks like science fiction, but we did start a pilot trial, which has some really nice results, which I'm going to tell you about right now. We had a control group with 13 healthy participants, 11 participants with depression, and 8 with schizophrenia or schizoaffective disorder. We gave them an audio band to record events from 8 a.m. to 8 p.m. every day for a week, and we recorded for a while. And this was a beautiful study, which showed us that our patients spend their time differentially based on what illness they have. That affects where they spend their time and how many people they spend their time with. So this was our first study, and it was about the ambiance. So ambiance is your group interaction. We're not talking dyadic yet. We will progress to talking about dyadic interaction with Dr. Sabarwal in the next section. The first challenge here was, how can I tell, without asking the patient, without listening to their words, if they are in a bedroom, in an office, in a bar, in a hospital, in a lecture room? And so that was a huge engineering challenge, which Dr. Sabarwal will talk about. But basically, the trick is I am getting those audio recordings, which are unconstrained. I am saying social ambiance is where the individual is, and social ambiance can be divided as I'm alone, or I'm with 1 or 2 people, or I'm in a big group, like with 5 people or more. We did match this with self-report psychometric measures. We're not at the intervention stage yet. Hopefully that will be our next stage. And here's what we found. So red is control group, yellow is depression, and green is psychosis. And what you'll see here, AL0 is time alone, AL1 is 1 to 2 people only, AL2 is 3 to 5 people, and AL3 is big group, 5 people. You will see that the time alone spreads variably for control group, but a lot of our depression and psychosis patients will spend a lot of time alone. That's in A. And you see that then our patients with depression and psychosis tend to spend a lot less time in ambiance measures that have more people. And so that showed us that this is probably something that we should pursue. And mind you, these are people who were well treated, suitable for outpatient management, no acute issues. So we're not even on the inpatient unit, but we were able to see that the group interactions with our patients were not the same as the control group. And so in summary, and again, this is foundational view, personal and systemic issues will need to be taken into account with technology implementation. We do expect the learning curve to be steep because we are going to have to go transdiagnostic, and we are going to have to go with dimensional, and dimensional is not what's common in psychiatry right now. So we do need to explain that both to the users and to the patients. We can look forward to a future, not so far future, where unobtrusive monitoring can be combined with smart personalized alert, and that could help us with symptomatic control. And we can certainly look forward to leverage those sociability bonds between individuals to both improve the therapeutic milieu on the inpatient unit, but also improve group and dyadic interactions outside once they get discharged from the inpatient unit. And I will cede the floor to Dr. Sabarwal now, who's going to talk to us about how we actually make this magic happen. And thank you very much for listening.
Excellent. Thanks, Nidal, and all my colleagues who've gone and set up the stage. My name is Ashu Sabharwal. I'm a professor of electrical and computer engineering at Rice University. So I'm going to kind of give a little bit of a preview of what type of technologies are coming up next, and especially with this example, which Nidal talked about, of being able to measure sociability of a person from free living audio. So Nidal kind of showed a picture where there was an audio band. So imagine having a wristwatch or a smartwatch, which today already has microphone and computing capabilities. What we want to do is imagine a next Apple Watch or a smartwatch, which can do privacy preserving sociability analysis from that existing technology. So what we did was use a new generation of artificial intelligence techniques which are coming around, which are really good at being able to take raw forms of data like audio data and convert it into intelligence. So this is a pipeline which we constructed, which allows us to take raw audio and process it using the modern tools to bring it to the point that we can start to extract the measures like network size, interaction parameters, and social ambience. One of the important things in any such technology development, which actually also was emphasized by Jessa and Peter, is that we need to actually make sure we are validating these things. We are actually have an understanding of how accurate they are, so our analysis can actually reflect that. So what we've done is, while we could not hear our patient data set, we have leveraged large amounts of open sourced data sets, audio data sets, which are made available by the engineering community, to use them as a benchmark for validation. And these data sets are labeled there. And so we can actually test what our methods do in relationship to the gold standard labels provided by these data sets. So this is how we have validated all our methods before we apply to any of the patient data. So just to flash again, what we have at our disposal is an audio band data where the patients wear this for a whole week, and it records audio from the 8 a.m. to 8 p.m. And it records continuous audio. In the current incarnation, we actually get the raw audio because we actually cannot program Apple Watch or any other watches, and they don't. Those interfaces are not available to us. But what we do is we take these recordings, download it to computer, run our algorithm. As Nidal said, we never hear what is actually being said, and then process that data to extract some of the measures. Just to give a sense, we actually have a very large amount of data, more than 1,600 hours of audio data from these participants from the sociability trial. So we do have significant data set to actually work and derive these results. And here is one of the important first plot, which talks about the PHQ on the x-axis and their average social graph size, that how many people per day they are actually meeting, unique people they're meeting per day. Okay. And what you find is a negative correlation. As the PHQ score goes higher, you actually find a significant negative correlation between the PHQ score and the average graph size. And this was one of the initial hypotheses before we started on this journey. And it was important to see that that hypothesis actually is true. The other thing which we found was that in terms of the size of the social network or the in-person social graph, there is a significant difference between the healthy and the depression group, which was something we had hypothesized. But we actually had an hypothesis that the psychosis group would actually have even smaller social network than depression group. Unfortunately, our data doesn't support that hypothesis. And we also didn't find a significant, maybe because of the size of the data, between the healthy and the psychosis group. They are smaller, but it wasn't significant in our data. I wanted to quickly highlight some of the more detailed information we can actually derive without, again, content analysis. So in our analysis, what we are doing is looking for somebody talking. And as somebody talks, if this is a speaker we have never heard before, we label them as a new unique speaker. We give them a label. Could be person 1, person 2, person 3. We don't know who they are, their identities, but we label them. And as we hear more of the audio of the algorithm process, if it hears the same people again, it concludes they might be in a conversation, especially if our patient is actually involved in it. And it then decides how many speakers are there in this conversation, and if there are 2 or more speakers. So currently we are focused on dyadic conversations. This is 2 people talking, mostly because we have the highest reliability in identifying dyadic interactions in our data set. And what you do is we actually taken our EcoNet algorithm, which I showed on page 1, and have modified it to actually extract these dyadic conversations. So this is a offshoot of that work, our own work, which allows us to now build a dyadic interaction detector. So it detects this and then computes certain parameters from these dyadic interactions. Again, as I said, with every time we build a new algorithm or a new method, we do an extensive validation. This is validation done on open source data sets. And you can see we actually achieve a pretty high accuracy in all our testing. And the reason for doing this is speech, free living speech is actually full of amazing sounds, so many sounds that actually many of them are not recognizable even by human speakers. So it's important for us to actually do this extensive validation among many free living scenarios. Now, the work on dyadic interactions actually has been analyzed before. So there is this work published in 2020 by Elmer et al., which actually gave students RFID tags to understand how their social interactions are and how big their social interaction groups are and what are the parameters of the dyadic interactions. And found actually a positive correlation between depression severity in this group and all the dyadic ratio they had, that means number of times dyadic interactions were detecting. How that means people who were more depressed in their group were actually talking more on one-on-one basis with more people. What our data set actually reveals something more actually, and the part of the reason is that the 2020 study actually had largely a healthy control group, and they actually had students, almost none of them were actually depressed, clinically depressed. So they were all on the low PHQ score, while our study actually has participants which actually span the whole spectrum. So what we find is that the dyadic ratio as defined by the Elmer et al. Work does show a positive correlation up to a certain level of PHQ-9, which is essentially healthy controls. And then for higher PHQs, you actually do get a negative correlation. That means they are talking less and also talking and having fewer one-on-one conversation as their PHQ increases. So this data actually has allowed us to figure out what is happening compared to a prior past work also. And then there are 2 other parameters which we have extracted from is what we call the pause time and the response time. Pause time, as this is how long you pause before you start responding to the question, and the response time is how long your responses are. Again, we actually don't find much of a correlation between pause time and the depression, but we do find a strong correlation is how long your responses are. So if your responses are shorter or longer, that seems to have a relationship to your PHQ score. Again, these are very small data sets, so they are early results. We definitely do need to run a larger studies and to actually validate these and actually reproduce these results. So the quick takeaways, just to kind of wrap up some of the discussion on this side is, we are imagining a future which is a higher amount of technologies available, allows us passive monitoring, and it does passive monitoring in ways which we cannot do today. In this case, sociability. So we want to understand what is your environment around you, so how many people you meet, what are your participation in that environment. And we want to do that all without content analysis. So we call that extracting quality of interaction or social interaction information purely from quantity of it. Who spoke, how long they spoke, and not what they said. And we are able to, using these modern tools, able to extract quite a bit of information even today. So with that, I'm going to pass it back to Jessa. Thank you.
Hello, can you hear me?
Yes.
Oh, excellent. Okay, so I'm just like so in awe of all of my, I don't know, are we called panelists? That was just so interesting. And it's just so cool to see how so many different people are implementing digital transformation across so many different settings and using so many different technologies. I'm just like so unbelievably impressed. So I'm just going to do a really quick summary and sort of like reorient us to the time framework. As a reminder, time is technology implementation for mental health and users. And the time framework captures these parallel processes of the what and the how, and we really were able to see that throughout the talk. So, for example, in the Q15 to remote patient monitoring, we were trying to decrease the touch in order to increase the tech with this monitoring dashboard and alerting protocol. And then Peter also gave us some good insight about how we can increase technology in order to optimize integrated data management systems. And then in Jan's, this one was really interesting, where she described sort of that balance of touch, the human side of care, in order to sort of optimize the integration of technology without sacrificing that crucial human element, which is just so important. And then Nidal gave us a really good foundational overview and understanding of cultural considerations that need to be made and operational challenges that sort of will be able to guide the balance of touch and tech and how we define innovation. And that sort of led into Ashu's presentation, which is just so interesting, and how we could increase technology in order to decrease touch and be able to create these high-tech prototypes where it's possible to capture the quality of the inpatient milieu or the quality of interactions and be able to quantify like the sociability of patients, which I didn't even know was a thing until a couple of days ago. So I just want to thank all of the fellow panelists and everyone for participating. I just want to keep this brief because we're all just so excited. So we were long-winded, mostly me, I set us back, but should pass it back to Michelle so we can have some Q&A just because I have questions, but I saw some in the chat, so we'll get back to that.
Yes, awesome. Yes, please, if you have questions, put them in the chat. So I'll just jump right into it. Thank you for attending. And there's a really great question. I love this question. The first one, this individual says, I feel like we are seeing the future of technology integrated care. I'm curious to hear more about the patient experience. Have you found that patients have faith in their care being so tied in with technology? Or have the panelists been met with any pushback from patients and participants? I realize that not all of the discussed technologies have been fully implemented clinically, but just curious. I think this is a great question, especially when we think about that intensive psychiatric setting. Who wants to, Jan, do you want to touch on this first?
Sure, yeah. So I think we are finding that when clinicians recommend the technology-based intervention, even if it's lighter touch like mine or have, more tech kind of sensors like the other panelists, that the clinician, the messaging really matters like this. And we always couch it, certainly with my patients, I'll say this will empower you to understand about your behavior, become a scientist in your own life. I think it's time now that we empower patients with their own data and teach patients how to, make changes in their own life based on their own data. And so, but I have gotten pushback. I work in a veteran population, older adults, not to, but I do think that this messaging is so key and consistency in messaging. The other thing, and then I'll zip it, is privacy really matters. And it doesn't have to be the same for everybody. So sometimes explaining it without getting too wonky about it, but just saying your data is only with me. Well, they come into my office and tell me all sorts of private things. They're happy to share their data with me. They don't want to share it with Jeff Bezos. I'm assuming he's not on this call. So I think that we just really need to learn how to communicate to patients in ways that are accessible and meaningful for them.
100%. Good points. Anyone else? Thoughts?
Yes, I think Ashu and I can also comment on this and link it to the next question. So when you are doing something very circumscribed, like a video call with a patient, you face the age issue a lot. So today, this morning, I had a follow-up patient and I had to show her how to open her text message and link to Doxy for a video visit. That's usually a very circumscribed function, and a little bit of education goes a long way. When you do audio band recording, you have to really be careful about explaining the privacy, no content analysis, we're not listening to your words, etc. And again, there's a big divide, I would say. It's very binary. Younger people and those with and those who are not paranoid are usually okay with it. The older you get, or depending on your personality, if you're a little bit more mistrustful or suspicious, or if you know a lot about technology, you're going to be very reluctant about that. We did implement some of that work, of course, with triple IRB approval, and people didn't have an issue recording other people. But I know that if we are to implement it on a large scale, we have to have a lot of legal and ethical considerations to consider.
Good points. Jessa, you want to comment a bit on like the trust and digital natives and migration and that? Jessa's been doing some really interesting work around that relates.
Yeah, so trust, and I really like, there's the figure that Nadal went over in her presentation that just kind of really like clearly outlines how psychopathology like underscores a lot of issues with trust and things that are barriers to trust. But right now we're really thinking about, in terms of innovation and in terms of integrating a new technology into a space where inherently people, there are barriers to trust. We really want to think about what are the categories of barriers. So for example, there are like cultural barriers. There are generational barriers. So for example, a digital native would be someone who grew up in the internet era, the age of the internet, whereas a digital immigrant would be someone who grew up without technology and all of these different things. So inherently, you're going to be more wary of technology, and you're not going to be as familiar with it because it's just not something that was a part of your childhood, your development years. So we really think about those sort of factors that guide trust and sort of like those overarching questions that, before anything else, determine sort of like the overall framework for if a person can trust this technology.
Wonderful. Okay. I think.
Can I just chime in though that we shouldn't forget that providers and clinicians are also, I don't want to say a barrier, but they are something to consider as well. We are a variable in this kind of model as well.
And the trust too, right?
Trust. That's where I go. Yes. We need to trust, and we need to trust technology and understand and be excited. And that's why I was saying about the messaging.
Yeah. I don't know how many times I have heard providers say, well, are the robots just going to do therapy, or, is AI?
I'm like, if robots can replace you, you need to go back to school. Ashu, we're not getting replaced anytime soon, are we?
No, not at all. Not even close. Nobody has anything to worry. Not in our lifetime.
Okay. And then Nadal, do you want to answer that last question on there? Or you? I saw you answer it written, but
I sent a written answer, but I would like to elaborate on that. So we started with dimensions mentioned in the RDoc, and sociability is a blended dimension, which is feeding off two areas in the RDoc. We are finding that we lack some normative data. So nobody can answer you if you say, how many friends should I have by the age of 20? Should I work remote? If I work remote, who's going to attend my wedding if I get married at 30? We lack that normative data for the population, and that is going to be very culturally dependent and socioculturally, really. So we are operating right now in the space of mental illness, that sociability is impaired. At some point, we will need large cohort data to tell us us what sociability should ideally be through the lifespan. We know that loneliness is a problem with the elderly. We know that loneliness is a problem with depression and social anxiety. So there's a lot of work to be done in this area. We are very careful when we do our foundational research to distinguish sociability from subjective aspects such as loneliness and from harsh self-assessments, because a lot of our patients do that. They assess themselves in negative situation. So they're really not assessing how they've done in this dyadic interaction well. So there's definitely some area for growth there in terms of intervention. And then in terms of scaling, I would really like to emphasize that a lot of measures we already implement. For example, social skills training. There are programs for that for our patients. So some of that will be making this into electronic delivery and using already existing principles. So we're making up some stuff, but we're using some stuff that's already validated, so to speak. And if Ashu could comment on the acquisition of third-party recordings, that would be great.
Yeah, so I think different actually states have different laws, but nonetheless, because we do zero content analysis or identity analysis, so we don't actually try to understand who is speaking other than our own part patient whose identity we know. I don't think we are actually stepping onto any recording laws, for example. So let's just take the legal aspect of it, and then there is a comfort or ethical aspect of it. And I think also, I think because there is no, again, analysis of content or identity, I think most people are going to be comfortable with it. So there is actually some of this is already being done on your Apple Watches, which actually looks for your audio volume. And if you look on your iPhone, it will tell you whether you were listening things, whether you are in a very loud scene or not. So this actually is already happening in a very, very simplified manner for certain things. But now the objective would be to actually have it as an app which you can turn on and off, even could be prescribed, and it extracts these quality metrics from purely quantity analysis.
Awesome. All right, any final comments from the panelists? Well, thank you for joining us today. This was wonderful, and we're so happy to be in contact. You feel free to please reach out to any of us, whether it's through the chat in the actual conference portal or through email as well. So we're happy, and obviously this takes a lot of collaboration and thinking together. I think that's something that we've realized in thinking about the time model. It's an evolving process, and but it's also worth it. Not many people are focusing in this area of more intensive psychiatric care and how we can reinvent it. And so if you're interested, we'd love to have you join us. And thank you all for coming today.
Thank you.
Take care.
Bye.
Thank
Have a good
you all.
afternoon.
Bye.